Okay, hey everyone. I think I've spoken with everyone before, so I'm Alison again. Thanks for joining us. So this is a topic that's titled SVT and Atrial Flutter, Meds or Ablation, and honestly this could really be answered in one slide, which is yes. Yes for ablation, but probably needs meds. But that being said, we're going to go through some of the data as well as just some of the practice recommendations for SVT. Like I started every one of my other talks, I like to do it with a case. I think it's more illustrative that way. It's actually a case that I did with Dr. Pacini in my fellowship. This is a 37-year-old professional musician who was touring through the area. It's actually a pretty prominent musician who's had a couple episodes of SVT, and while he was on stage had pretty sudden onset tachypalpitations. I think he actually played through the concert, but had enough sustained tachypalpitations that he actually was brought to the emergency room. And when he showed up, he was in this rhythm, which you can tell is very, very fast and very narrow. He didn't pass out. Didn't have any other symptoms other than the fact that he was very bothered by it. I think he did have a little bit of chest discomfort while he was going so fast. And again, he's had this a couple times throughout. Nothing that was sustained enough. He went to caught by the emergency room, but definitely something that we see pretty commonly in people who have SVT. They'll say, yeah, you know, a couple episodes, or it may only last a few seconds, or once in a while it will last a little bit longer and I'll cough, and I'll get rid of it, or it makes me cough, or so forth. But typical, pretty straightforward, pretty similar history. And so that's a good introduction on what do we do with patients like this. So there is guidelines on SVT. This is the latest guidelines from 2015. This slide really just goes through the differential diagnosis. I'm going to skip through it a little bit because I think, to be honest, a lot of this is oftentimes just an exercise in being an academic, going through the EKG, trying to look for these little tiny P waves when the guy's heart is going 200 beats a minute, and the P wave is either buried in the QRS or it's in the T wave, and it's very difficult to see, even for an electrophysiologist. And sometimes, yes, sometimes it's straightforward and you can say, I'm pretty sure this is it. But even when we do that, we still need to confirm with EP studies, and more often than not, we're wrong. So is there a benefit? I think probably the biggest benefit is being able to differentiate atrial fibrillation and atrial flutter from some other type of SVT. And that is either things like atrial ventricular nodal reentrant, or AVNRT, or WPW, or atrial tachycardia. I think making that difference is a big deal. Because if you have somebody who's having an AFib or an atrial flutter, then the idea of anticoagulation, as you all know very well, becomes that much more important. And AFib, I think, is pretty straightforward. If it's very, very, very irregular, you probably have to err on the side of being an atrial fibrillation. And flutter, although very difficult to sometimes discern from other irregular heart rhythms, does have a characteristic pattern, and we'll talk about ways of doing this. But probably one of the easiest things to do is to just look at the distribution of age. Now, I took out atrial fib and atrial flutter from this. This is just the other types of SVT, which we typically think about as atrial tachycardia, AVNRT, or AVRT. AVRT is, otherwise, you can think about it as an accessory pathway, or WPW. It's short for atrial ventricular reentrant. AVNRT has the node. And you can see that the distribution changes as we age. So as you're younger, you're more likely to have WPW as a mechanism, but more than likely, if you're having symptomatic SVT, you're going to present earlier in life. So as you make it to the time you're 75 years old, you probably would have presented with WPW sometime earlier, so that becomes a lot less likely. AVNRT is probably the most common through this whole distribution. You'll see it gets more common. There's also a difference between gender and age. And so for right here, you can see, again, this is very similar to what I just showed before. And then between male and females, you can see that AVNRT is probably the biggest one. That's the biggest differentiation being more common in females than males. Why does that help? Well, we'll go over it a little bit because I think it does help. It helps you because some of these arrhythmias are more treatable than others, and AV-NRT is one of these things that's more treatable. So let's go through the treatment. Well, the first thing, if we take our patient, he shows up to the emergency room, we're really thinking about what's the acute treatment of SVT. He obviously made it enough to get a 12-lead EKG, so he's either on his way to be hemodynamically unstable or he's hemodynamically stable. Because typically if you're going at 190 or 200 beats a minute and you're unstable, they probably would have taken care of it already before getting a full 12 lead. But that being said, I think that again is probably the first entry point or the bridge point where you say, is this unstable or stable? And in the case where it's unstable, then you go for cardioversion. Or if it's a regular SVT, you may be able to do adenosine before you do anything else, or if it's a narrow complex regular SVT. After that, if it is hemodynamically stable and you've tried adenosine and you've tried vagal maneuvers, then that's when you start to talk about medications to try to slow down the heart. So why is this? What is this whole point of this? Why do vagal maneuvers and why did adenosine work? The reason why these work is you just have to think, I'm going to jump ahead real quick, is to think about the mechanisms of what these SVTs are. Right, we talked about the SVT as being an AV node reentrant tachycardia. We also talked about WPW. But the things that those two have in common is that if you think about AV-NRT, which we said that it was the most common type of regular heart rhythm, it's something that involves the AV node. The AV node is very, very, very sensitive to the vagal tone. So it's sort of like when you hold your breath, you slow down your heart rate, or you have a dive reflex. You send all these inputs down to the AV node to be able to end up slowing that AV node conduction. If you do that enough, which is Valsalva maneuvers and all those vagal maneuvers, then you might be able to break the tachycardia. Now it turns out the AV-NRT is not the only regular heart rhythm that uses the AV node. In fact, accessory pathways, or WPW, also uses the AV node. The idea is it's a shortcut, but it's only a one-way shortcut most of the time. It still has got to go through the AV node, then it comes back up the shortcut and down the AV node, or it goes the opposite, it goes down the shortcut, then up the AV node. But because it uses the AV node, if you do something to try to stop the AV node from conducting, then you have a good shot of potentially actually stopping that irregular heart rhythm. Okay, so doing things to the AV node is extremely important. And so using vagal maneuvers and or adenosine, as you know, also affects AV node conduction, is a really effective first-line therapy for narrow complex tachycardia, and it'll take care of more than one. The other thing that's important about it, like we talked about atrial flutter, is that if, especially with adenosine, if it blocks the AV node, you may be able to unveil something else that happens. So in the setting of AV-NRT, right, this is a regular heart rhythm that spins around the AV node, our accessory pathway that spins around the AV node, and the rest of the heart. If you have atrial flutter is a regular heart rhythm circuit that circles around the atrium. It doesn't involve the actual AV node. So if you give adenosine to somebody, you may see heart block where there's no ventricle conduction, but you'll see flutter waves, and that may actually help you with your diagnosis. So not only is it therapeutic, it's potentially diagnostic as well too. You may see atrial tachycardia, which is also not involving the AV node. So you try that first, you try your vagal maneuvers, you try your adenosine, and then you can go down to the next part, which is try to slow this down. And that may be with beta blockers or calcium channel blockers before you go. Okay, so the acute management usually is pretty straightforward, right? Someone comes in really, really fast, you try to get them out of it. Vagal maneuvers, adenosine, or some beta blockers and calcium channel blockers. But more so, especially in this audience where we're talking about, you know, primary care or hospitalists or so forth, the question is, what do you do now? What do we decide once we have the person out of the SVT? Do we send them for ablation? Do we do antiarrhythmics, or do we just use simple beta blockers? And when you think about that decision, everything's risk-benefit. If the risk of the procedure is very high, then it doesn't matter what the benefit is. You may not end up doing it. If the risk is very low, and it's curative, you may do that. The same thing with the medications. Although we use beta blockers and calcium channel blockers all the time, in patients that have SVT, you might be talking about an 18-year-old or a 22-year-old or a 28-year-old or whatever that may not want to be on beta blockers or may not be able to tolerate beta blockers because of the side effects for those profile. So the decision always comes in the beginning. It says when you think about somebody who has SVT or the chronic management of SVT, the answer first is, do we think about pursuing ablation? The idea of ablation comes in right in the beginning, to be honest. And the reason why is because it offers a potential cure for most causes of SVT, and I'll show you the data in a second. But it also is patient preference. If the patient prefers not to have an ablation, then you go to medical therapy. The medical therapy may consist of antiarrhythmics, specialized things that flecainide or sotalol, or maybe it's as simple as beta blockers and calcium channel blockers. But ultimately, if the medical therapy is ineffective, then you go back to the EP study and potential catheter ablation. So you can see in the latest guidelines and for treatment for SVT, if you follow down the algorithm, you can start with SVT, pre-excitation, yes or no, that means WPW. Does the patient have an ablation, want an ablation? Is the candidate? The answer is yes. You can go straight to ablation. That's a class 1, straight for SVT. That means without even trying medications. Or if they don't prefer ablation or they're not a good candidate for whatever reason, and we can talk about that afterwards, then you can go to medical therapy. And in most cases for medical therapy, I think most of us will start simple before you go up to more complex meds. So beta blockers, calcium channel blockers, before talking about antiarrhythmics, and that is what the guidelines suggest. This is a busy slide, but really is just showing you different types of flutter. The idea is uncovering flutter and looking for flutter waves or constant flutter is also going to be very helpful for us in trying to figure out what to do. And again, if you go through the guidelines, the idea is also for a class 1 indication is either a rate or rhythm control. But in this case, for atrial flutter, rhythm control is also an ablation of class 1 indication. So the reason why is flutter, I'm jumping around from SVT to flutter, I apologize, but I want to make sure we talk about the flutter. Why is flutter why is there a class 1 indication for flutter for ablation, and there's not necessarily that for an atrial fibrillation? Or why do we think about flutter right off the bat as opposed to atrial fibrillation? Well, one of the reasons, and two of the reasons, is one is it's very difficult to rate control atrial flutter. Very difficult to rate control atrial flutter. And anyone who's ever tried to do it knows you may think you have rate control, and as soon as they start walking around, all of a sudden they're going 150 again and don't tolerate it very well. And number two is the therapy that we use for ablation is actually very highly successful. So why is it this is a digression, why is atrial flutter so much more difficult than atrial fib? You would think that atrial fib, which causes the atrium to go so fast, 400, 500 beats a minute, should cause the ventricle to go faster than something that goes a little bit slower, which is typically around 300 beats a minute. Well, the answer is the refractoriness of the AV node. Refractoriness is essentially a term that means how fast the AV node resets. And I like to think about it sort of like a toilet bowl. So if you have a toilet bowl, you flush the toilet bowl and you let it reset, it works fine. If you're in sinus rhythm, you flush it 60 beats a minute or whatever it is, you give it enough time to reset, it works totally great. But if you sit there and you hit that flush, you just hit it over and over and over and over again, what ends up happening is you stimulate that toilet, and you never actually get a good reset. It doesn't reset, so it takes a lot longer to actually flush. You're more likely to get more flushes with a slower rhythmic stimulation than you would be if you were bombarding that stimulation. Does that make sense? That's why atrial fib is usually much easier to rate control than atrial flutter. Flutter, because of that slower pace, and it just so happens to hit the AV node right when it's able to conduct, oftentimes conducts much faster and is much more difficult to rate control. Okay, so this is a group of, I guess, hospitalists and primary care physicians, and because of that, I just wanted to at least show you what we do in EP study, so it doesn't seem like when you refer someone to ablation, it's this very scary thing of, we're burning your heart. The idea of ablation in EP studies is really we're just trying to map the electrical system of the heart. We want to see where electricity flows through the heart. In order to do so, we put these thin little catheters up with little metal electrodes. And they go out throughout the heart, so we can actually see electricity flow. When we do so, you can actually map out flow of electricity. You see where the atrium is. You actually can see the bubble of His. You can see where electricity flows through the His and then down to the ventricle. You can see from the left side of the heart to the right side of the heart and the top to the bottom. And it really creates a map for us. And once we do this, and this is from Dr. Puccini, we can use this three-dimensional mapping systems. This is, let's see if it'll play. We can use this three-dimensional mapping system that essentially creates an electrical anatomical map of electricity as it's flowing. As you can see, you saw some color that's sort of flying through. It goes in a circle. This is actually a really remarkable video. And John, did you submit this?
Yes, we did.
Did it get published?
We're in negotiation.
Okay. Well, this, if you can actually see, is one of the first recordings of AVNRT on a 3D anatomical mapping system. So theoretically, this is actual electricity that's going down and circling around the AV node. So you're actually visually looking at how electricity is flowing through the AV node. So that's AVNRT. And that's what we do is with these mapping systems, we take, it's like sort of Marco Polo. We take points in the air and say, am I closer to this electrical system? Am I closer here or further? Am I closer here or further? Am I closer here or further? And once we say all those points together, then we can see how electricity flows through the heart. By doing so, we can really localize the type of irregular heart rhythm the person is having, and also to the point where it is. So again, if this is irregular heart rhythms, and WPW is at the top over here, there's an accessory pathway here. AVNRT is a big circle around the AV node with a pathway here, and atrial flutter is a big circuit around the tricuspid valve in the right atrium. The way we do ablation is essentially cut out. It's like putting a roadblock in a racetrack. You're not letting the electricity spin around anymore. You're putting that roadblock in, the electricity hits that roadblock and it terminates and it's done. And it can't continue anymore. Okay? And so that type of targeted, we can see the electricity, we can target it, and then we can get rid of it. And when we do so, we can actually be pretty darn successful at it. So let's look at the recurrence rates for AVNRT, AVRT, and atrial flutter on drugs. The recurrence rate on the ones to the left, that's WW, AVNRT, is about 20%. That's on antiarrhythmics, so that's already on someone who's taking the risk and side effects of antiarrhythmics. On atrial flutter, the recurrence is much higher than that, 55%, as high as 60% in the long term, even with antiarrhythmics. That's quite high. That also means that they're on antiarrhythmics, so whatever your patient population is, you're thinking about putting them on drugs like sotalol, flecainide, ibuprofen, whatever. That could potentially be lifelong. Let's look at ablation. This is acute success. Recurrence rates are very similar to this, but acute success for AVNRT ablation is 98%, WPW 99%, and atrial flutter 95% success rates. Now the recurrence rates of AVNRT is about 3 to 6% sometimes in the literature, and atrial flutter maybe about 10% in the literature. So you're talking about success rates where for cure. Cure is not very often said in medicine. We say treat a lot. We don't say cure a lot. But I tell patients this is akin to potentially scooping out a mole. Once it's gone, it may never come back. Okay. Now, complication rate, that's the most important thing here, right? Otherwise, we would just send everybody. Anytime you saw SVT or flutter, there would be no question. Everyone would go straight to ablation. We have to worry about and think about complication rates. But if you look at the complication rates, the risk is actually pretty darn small. 0 to 2%, and this compilation, AVNRT is 1.2%, and flutter is less than 1%. To be honest, those complication rates are probably pretty accurate, but probably even a little bit smaller in modern day mapping. But complications are potentially devastating, not life-threatening. If you have a complication for AVNRT, it's unlikely to be life-threatening, but the complication may be a pacemaker. So you're talking about a 20-year-old, college sophomore who comes in with SVT and then all of a sudden leaves the EP lab with a pacemaker. That would be horrible. That would be devastating for that person. And that certainly weighs in you when you make that decision. But when you also think about that 20-year-old who has to be on beta blockers for the rest of their life and either doesn't tolerate it, and you think about the complication rate being less than 1% in a population like that, then to be honest, the choice actually seems to favor ablation over medications. But let's look a little bit carefully about the complications, because we do need to think about some of the more dangerous complications, and those include things like cardiac tamponade, pulmonary embolisms, pneumothorax, or pericarditis, or so forth. And again, you can see that for the most part, the incidence is pretty low. I will say, most of the time, for most of our operators, we would say you can never say zero, no doubt about it. There's anatomical differences that you just never can predict. But there are oftentimes also areas of gray where we say this is a high-risk place, we're going to stop. This person is 18 years old or hasn't had tried anything, you might not push more aggressively. So these numbers, although are hard and true, there's some gray area there where we're more able to say we're very close to the dangerous electrical conduction system, maybe we should stop and not push forward, or this person is going to the emergency room 3 times a month, passing out, hurting themselves. We need to get this, otherwise they can't live their life, and you may push a little bit harder. These are all common numbers, but I still think there are certainly reasonable numbers in favor of a potential cure for this rhythm. And then the last thing to talk about is actually the recurrence rate of atrial flutter as well as atrial fibrillation. This is a big deal because unlike SVT, where if you go after the AVNRT or something, you take it out, it's done. Atrial flutter oftentimes has the same predisposing risk factors as people with atrial fibrillation. And in a lot of studies, the rate of atrial fibrillation and atrial flutter concurrence is about 20 to 30%. And this study was up to even 40%, depending on the follow-up. And the follow-up is very extended follow-up. You can see almost 8 years here in follow-up. So if you have somebody with atrial flutter, the reason why is probably because they have some disease in the atrium, which then predisposes them to AFib. If they're going to have AFib anyways, maybe you say, maybe just use medication and not do the ablation. We talked about that already, and that atrial flutter is much harder to control, so I would say that's not the same. But the incidence in people who have AFib, group 1 in this study is people who haven't had a history of AFib, and you can see up to about 8 years, 9 years, about 40% of them may develop AFib. That's after 8 years though. In the group that has AFib to begin with, obviously they have AFib after the flutter ablation, but that's expected. But again, AFib usually easier to rate control and usually less symptomatic than atrial flutter is. I think that's it. This is just the final sort of algorithm on how to sort of manage. And just like the other talks we talked about today, I think symptoms is key. If you have mild symptoms or no symptoms at all, I mean, I think unless you're in an incessant tachycardia, which may lead to some cardiomyopathy, using therapy I think is optional. If you have severe symptoms, that's pretty straightforward. You got to take care of it. Use the most definitive therapy, which is catheter ablation. And then in the middle, which most patients sort of fall into, I think is patient preference. That being said, the more and more, and as you saw that beautiful map that we had of AVNRT, the better technology gets, the more and more that we have more experience doing these ablations, the more and more I think patients are also understanding and being more willing to say, if I undergo this same day procedure, same day, 2 hour, maybe even less than that procedure, and I'm cured, never have to take medication ever again, most patients actually prefer that as opposed to being on medications indefinitely. And again, it is true. It is, for most of SVT ablations, we're talking about a same-day outpatient procedure. For the most part, a couple hours, if not shorter. The patient that I started to begin with, he actually had WPW. We successfully ablated it, and from all intents and purposes we can find out, since he's still on tour and doing well, has not had a recurrence, or at least as far as that we know of. So for someone who's on stage, had to get taken to the emergency room, that's pretty clear cut, I think. That's life altering for that person. Gets an ablation and is cured. Thanks.